Evening. Good evening. Can everybody hear me? Sitting in the back, can you hear me? Okay, all right. I'm just going to do my own introduction. My name is Dr. Neasman. I'm an interventional cardiologist. That means that I open arteries. I open arteries anywhere in the body, pretty much. Those arteries going to the heart, the brain, the arms, the legs, the arteries going to the kidneys, the arteries going to the intestines. Wherever these major arteries can be blocked, I can usually get to them and open them. Okay? So opening them with balloons, with stents, with devices that cut the plaque out, devices that sand the plaque off. We even have a laser that we use sometimes. Okay? So what I'm going to do today, we're going to talk about this blockages issue and why you may or may not have, and if so, what we do about it, how to do something about it. All right. Now, I'm going to let this play a little bit. Can you see the blockage right there? Can you see that? Yes? Can you see it? Yes? This thing right here. So when I let it play, this thing right here is a lot smaller than that normal part of the artery. Right? All right, I'm going to let it play now. Now, this is a picture of the LAD. It's the name of a coronary artery, the left anterior descending. And it was actually, this picture was taken because a patient came into the emergency room having chest pain. His electrocardiogram looked like he was having a heart attack, which he was. Fortunately for him, his artery was open a little bit. Normally, it's completely closed. So right this moment, this person's having a heart attack. We rushed him from the emergency room to the cath lab. And you see this? Okay, that's a catheter. This little thing is a guide wire. This is a balloon with a stent on it that's being inflated and deployed right where that blockage was. And after we finish that, that's what the artery looks like. Okay? That's what the artery looks like. So now the heart attack stopped. Chest discomfort's gone away. And now the issue gets to be, why did all of this happen in the first place? Why did that person have a heart attack and another person may not have? So if any of you have had blockages anywhere, what made you have blockages and someone else maybe not? Now, as I said earlier, blockages can occur in these arteries feeding the heart attack. They can occur in these arteries going to the brain, stroke, and there are different kinds of strokes. They can occur in these arteries going out to your arms. These are your kidneys, and these arteries feeding your kidneys can also have blockages. This is the major artery feeding the intestines. So there can be major blockages in the arteries feeding the intestines. These are the arteries going to the legs. There can be major arteries, major blockages in those arteries going to the legs. And so again, the issue gets to be, why does one person have blockages and someone else doesn't? Now sometimes I would just ask the audience to tell me why they think, but what I wanted to do was just to have in front of you what the risk factors are. Okay? Now, I didn't put genes as in genetics, as in your family, your parents. So genetics certainly plays a role. But the top of the list, anywhere in the country, but especially here in the Valley, is diabetes. So patients who have diabetes have a significantly higher possibility of developing blockages than people who don't. Okay? Next on this list is smoking. I mean, I've had some patients who almost refuse to believe that smoking is causing them to have blockages. And they have blockages in their heart and they develop it somewhere else. And after about 3 or 4 distributions, meaning 3 or 4 different places in their body that develop blockages, they start to think, okay, maybe I ought to stop smoking. Smoking is a major big deal. And actually, it's the second one on the list because it's so important. If you have a history of blockages anyplace already, well, you're at risk for having blockages other places because of the same risk factors. A high cholesterol is on the list, high blood pressure is on the list, sitting down doing very little physical activity and being overweight is on the list, being male is on the list, age, as age increases, on the list. Now, we have to be careful when we talk about males being on the list because early on, I mean years and years and years ago, because we knew that male patients had more blockage, more possibility of developing blockages than female patients, what happened is that doctors sort of poo-pooed the female patient. Okay, I mean, to tell them, well, your problem is depression, your problem is anxiety, your problem is menopause, your problem is hormones, you know. So for a long time, we really didn't understand that women also have a very high incidence of blockages, particularly heart-wise. And the other thing that we realized is that the symptoms that we learned and we read about in the textbook, I mean, that elephant sitting on your chest, going to your back, associated with, you know, shortness of breath, nausea and sweating, the lady patient may not have those things. It may just be, I just don't feel well and I don't know why. Or I'm short of breath and I don't know why. Today I'm just tired and I'm not a person who's tired. Something's different about me today. And all of those symptoms, something that happens out of the blue, needs to be looked at. And I'm, you know, specifically directing those comments to our female patients. It may not be the things that we all wrote and read about that were basically male symptoms. Okay? Now, if you're diabetic and you have high blood pressure, it's really the risk factors compound themselves. 2/3 of patients with diabetes die because of heart disease. Now, is there anybody here in the audience who's not diabetic now, but you've had a heart attack already? Okay, not diabetic, but you've had not diabetic, but you've had a heart attack. Okay, not diabetic, but you've had a heart attack. Just stand up for a moment. Okay, but listen now. No diabetes, and she's had a heart attack already, right now. All right, now, somebody in the audience who's diabetic and they've never had a heart attack. Okay, diabetic, so now listen to me very carefully. The diabetics who've never had a heart attack are at the same risk of having a heart attack as this non-diabetic lady who's already had a heart attack. Okay? It's a big deal. Thanks, you can sit down. Thank you. And this slide shows what I just said. So the non-diabetic patient who's had a heart attack already in yellow is at the same risk of having a heart attack as the diabetic patient who's never had one in green. Okay? So just remember that from a diabetes standpoint. Now, this JNC is Joint National Commission. There's an 8 now, not just a 7. it is very important to control the diabetes and control the high blood pressure, especially. And it's not just a matter of taking your medicines. If you're taking medicines for high blood pressure, but your blood pressure is not controlled, if you're taking medicines for your diabetes, but your diabetes is not controlled, just taking the medicines doesn't give you the goal. And the goal is going to be reducing your cardiovascular risk. So what do you get? What do you get, especially the diabetic patient, what do you get from lowering your blood pressure? Less heart attack, less kidney failure, less stroke, less vision deterioration, and less heart failure. What do you get from controlling your diabetes? And we're going to talk about what control actually means. So you have diabetes. What do you get if you control your diabetes? Decreased heart attack, decreased stroke, decreased heart failure. All of those things go down. What does it mean to control your diabetes? Okay, is that the fasting blood sugar less than, 100 and something, or 100? Do you know that you can pig out all week long, become a saint eating-wise over the weekend, have your blood test on Monday before you're going to see your doctor on Wednesday maybe, and your fasting blood sugar going to look fine? So that fasting blood sugar is not the definition of control anymore. It's this thing. It's this thing. This is a hemoglobin A1C, which looks 3 months backwards at how well your diabetes was controlled. Okay? Can't fool it. Can't fool it. Everyone who's diabetic needs to know what their hemoglobin A1C is. Because that slide of diabetic control, those are the things that you get when your hemoglobin A1C is less than 7. Now, who's responsible for the control of the risk factors, whether it be high blood pressure, diabetes, high cholesterol? Who's responsible? Okay? You're right. 2 people are responsible. You're responsible. Your doc's responsible. You're responsible for taking the medicines, appropriate medicines, adhering to a diet, getting as much exercise as you can. Your doc's responsible for giving you the proper medicines, following you appropriately, and making sure that those medications work. So diabetic patients now, if you're working with your doc and the hemoglobin A1C is not less than 7, and you're doing your part, we want the doc to be able to do their part. Sometimes there needs to be a diabetic specialist if the primary care doc can't make this hemoglobin A1C less than 7. Okay? So it's going to be it's very important for you to know what your blood pressures are, what your hemoglobin A1C is. And we'll talk a little bit about cholesterol. It's very important to have a normal or lower the cholesterol, especially if there are blockages. Now, there are actually some people who have what appears to be a normal cholesterol, and they've had a heart attack. Okay? And so we might think, why even give that patient a cholesterol-lowering drug if their cholesterol is normal? But remember, they've had a heart attack already, or they've had a blockage anywhere else. Your body needs cholesterol. If I made your cholesterol 0, eventually you would die. Your body makes cholesterol. So when we do the blood test, part of what we're seeing is what your body's making. Part of what we're seeing is what you're ingesting diet-wise. So if that patient even has a normal cholesterol, you know what it means? It means that the body isn't doing something right with the cholesterol that it has. So even that person with a normal cholesterol, if there are blockages, I'm going to put them on a cholesterol drug anyway, because there's one other part to this. Some of the cholesterol-lowering drugs have the ability to stabilize the plaque. So once there's a blockage there, yes, I'm interested in lowering the cholesterol, but I'm interested in stabilizing the plaque. So these plaque stabilization drugs, Provocal is one, Simvastatin is one, Lipitor is one, Crestor is coming along. So once a blockage is there, the cholesterol needs to be managed for a different reason. If you happen to have a 50% blockage in an artery and it stays 50%, I'm going to be very happy. Okay? We don't want it to progress, and therefore using the cholesterol-lowering drug for that purpose is why we would do it. All right, just a little bit about the peripheral arteries. Now, these are the arteries away from the heart, especially in the legs. Many patients have leg discomfort when they walk, cramping when they walk, fatigue in the legs when they walk. Now, it may just not be because there's been another birthday. Okay? I mean, it's very easy to say, oh, you're X number of years old and that's why your legs are hurting. I mean, maybe that's the truth, maybe not. It's very simple for your physician, your primary care physician, to examine you to see if there are pulses in your legs or order a very simple test to see if you have peripheral artery disease. A lot of people have peripheral artery disease. When you see patients with amputations, that could have been a motor vehicle accident, that there was so much trauma not to save the leg, but more than likely, especially here in the valley, it's peripheral artery disease. And that limb was removed because it didn't have enough blood flow. Let's see if we can get something else. So, when you walk across the Progresso Bridge and you have to stop because of something going on in your legs, it may not be just because you're, pick an age number. I'm not going to say one because that would mean I'm picking on someone. I don't want to do that. But it may be because the legs really aren't getting enough blood flow. If there's fatigue, if you're just slowing down. Patients are remaining active longer and longer and longer. One of the most important questions that I ask a patient when they come into my office is to tell me about the physical activity that they're doing. And I want to make sure it's the same as the last visit. So if you are not able to do as much as you did 6 months ago, it may not be because you've had another birthday. It may be because something's wrong. And that something could be a thyroid issue, it could be diabetes not controlled, it could be anemia, it could be blockages. So the important thing, if your physical activity has now drastically changed, you want to see your doc to make sure there's not something that can be improved in order to improve your functional capacity. So that brings us back to all the arteries. There are major blockages that we can fix. I'll just go over a few of the well-known symptoms in other places. If there's a blockage in an arm artery, there may be discomfort in that arm when you use it. I'm not exactly talking about a shoulder pain, but using the muscles of the arm, if the muscles aren't getting enough blood flow, that arm may be fatigued. And I'm pointing at this drawing's left arm because most often it is the left arm. Most often it is the left arm. If you have high blood pressure that just can't be controlled no matter what you do, no matter what your doc does, there may be blockages in these arteries going to your kidneys. And if we find those blockages, opening them, simple balloons and stents, blood pressure goes down. But we have to look for it, and you have to be aware that you're doing everything that you're supposed to do blood pressure-wise. Your doc's doing everything that your doc can do blood pressure-wise. It may be time to look for something else. There are people who develop blockages in these arteries going to the intestines. Most of them are women, and most of them are over the age of 70. So the patient who starts to have abdominal discomfort when the patient eats, to the point that they stop or drastically decrease how much they eat just not to eat, to not have the discomfort, to the point that weight starts to go down, dress sizes start to go down, something's wrong. And the something may be a blockage in one of these arteries going to the intestines, which we can get to very quickly and easily and open and have it go away. I actually had a patient referred to me who was in the same category. It was a lady patient, dropping dress sizes, not eating. And this had been going on so long that she had actually forgotten why she started eating so little. But she was also having diarrhea, and her doctor, her primary care doc, was working her up for the diarrhea. We happened to find the blockage. I open the blockage. I get a phone call several weeks later from the primary care doc to say Mrs. Rodriguez is now constipated for the first time in the last X number of years. So all of those symptoms were related to the blockage. Okay? The important part about the intestinal issue, though, is the weight loss. Okay? Is the weight loss. So it's not just having a little diarrhea, go see if you have a blockage. It's something that now has been going on for such a long time, losing weight. Okay? Back to the blockages in the legs, we talked about the discomfort, particularly in the calves or the muscles of the thighs when walking. The other side of that is someone who actually has ulcers or sores on the feet that are not healing because the feet or the toes are not getting enough blood flow. We did a case this morning of actually a 35-year-old lady who was diabetic. Kidney failure to the point of being on dialysis, has an ulcer on one of the toes of her right foot. We found a total blockage just above the knee. And that ulcer was not going to get better. She was headed toward amputation if it didn't get better, but we opened that artery this morning and it just looked beautiful. So I expect that ulcer to heal. She's not going to need an amputation. So the important things from this evening are the risk factors. I mean, those things that make your risk higher than someone else's, and controlling the risk factors. Okay? All right. Questions now. Leave time for questions. Yes?
The smoking, how does smoking develop into heart problems?
Okay. Smoking irritates the arteries. It actually causes your body to lay down plaque, and it's not the nicotine. It's the carbons. It's the other components of the smoke that actually is an irritant to the arteries. And so when you add that to someone who is hypertensive or diabetic, you compound the issue. Okay? Now stay on smoking for just a moment. Do you know how hard it is to stop smoking for someone who's been smoking for 20, 30 years?
Very.
It's very easy for the doctor to say, oh, stop smoking, stop smoking. But it's very difficult to actually do. You know why? Now it's become a brain thing. Okay? It's become a brain thing. The brain wants something in the fingers. The brain wants something in the shirt pocket. The brain wants something at a particular time of day. Coffee time, cigarette time. The brain wants to see smoke. The brain wants a taste. The brain wants a smell. Most of my patients now who are drastically decreasing their smoking, they're using what? The electronic cigarette. Okay? The patches and the pills don't work for everybody. The electronic cigarette is the thing that satisfies what the brain wants. The brain wants something in the fingers, the brain wants something in the mouth, the brain wants a taste, a smell, to see something. So my patients now who try the electronic cigarettes, their cigarette smoking cut in half just about right off the bat. So from 2 packs to 1. Now, going from 1 and below, that gets to be hard, but they can almost immediately cut their use in half. I have one patient who said, well, I didn't like that flavor, I'm trying another flavor. And I said, fine, try all the flavors, because it's just that important. I have one patient who walks around with 2 of them in his pocket so he can use whichever one he wants. So if any of you smoke, now listen, there's no comparison data with electronic cigarettes as in one better than the other. There's none of that. There's none of that. The electronic cigarettes do have nicotine, but sometimes we give you nicotine patches. So nicotine's not the problem. It's the carcinogens and the other aspects of the smoke that's the problem. So if you smoke, give your choice of an electronic cigarette a try to see if you can decrease the amount. Yes?
My doctor told me that I had blockages right here in my arm. I keep feeling like a lot of pain in my vein. I started with this one, and then now I'm going through this one. And my doctor told me, you have to wait, because this one is doing the job and this one is not. Until you have a severe pain, you go to the ER. I said, well, I'm feeling very sweaty, I'm really active. I feel feeling very tired, very sweaty and stuff. Even though I'm in the air conditioning, but at night, I'm sweating a lot. And I can feel like my stomach's very full.
But now, did your doctor tell you that the only place that you had the blockages were in your arms?
Well, they've been trying to locate me here. I thought it was here now. I have it here. And he made me a blood test, Dr. Roa, and he told me that I had a blockage right here. And I feel pain sometimes. And whenever it gets worse, or you get like something, color here, yellow or something, go to the ER, don't wait. And I can have pain here, and I want
Yeah,
to
those arteries in the lower part of your arm are they do get small, and they may be too small for us to open. The more important thing is, do you have blockages higher up? Because if there are blockages higher up here, as opposed to these smaller ones, those can be opened. These down here, it gets to be very small, and it's difficult to open those. Okay? Yes?
The cholesterol, I received a newsletter from people that have natural stuff to fix the cholesterol. They're saying that that's really not a problem. The problem starts in the things that are supposed to take care of the cholesterol lowering medication. Is that true?
There are natural ways of lowering cholesterol, which is fine, except for one thing. And the one thing gets to be if you have blockage already. Because remember, I talked about that plaque stabilization thing. Those other remedies have been proven to lower your cholesterol. That's great. But they haven't been proven to stabilize the plaque. Different ballgame. I even have patients who want to do the chelation therapy. Anybody here do any chelation therapy? I mean, where you take something that's going to extract the calcium out of your arteries first, it doesn't work. But the second thing is that the agreement that I make with my patients who think they want to try that is they can do it as long as they continue to take the things that I'm giving them. Okay?
So there is nothing natural that you can eat that will help reduce the plaque?
There's not anything that's going to take the calcium out of that plaque. Stabilizing it, so anything that's going to lower your cholesterol in conjunction with the medicines. Okay? And that's why I want to separate your cholesterol number from the stabilization of the plaque. So all of the remedies that lower your cholesterol, they've not been proven to stabilize the plaque. Okay? So not going to tell you that you can't lower your cholesterol with the medicines. You actually, with the alternatives, you actually can. But I want more.
So without taking the drugs themselves, you can't get rid of that plaque?
Correct. Stabilizing it. Now, it's very rare. Now we over the years have tried to do plaque regression studies. What can we do? Put the catheter in, take a picture, see an 80% blockage today, do something to you, and 6 months later take a picture later and see if that 80% is now 60. And we've tried to do that, and we've tried to do that, and we've tried to do that. And what we find is that for every place where it looks like the plaque is a little bit less, there's a place that the plaque is a little bit more, and it evens out. So again, the other alternatives can lower your cholesterol, but not proven to stabilize the plaque. And the most important thing that I can do for a person who has already had a problem with a blockage is to try to prevent them from having another problem with the blockage. That's where the plaque stabilization comes in.
Are they working on something that maybe you could, or would have to be put into the bloodstream that maybe would dissolve some of that plaque, make it a liquid, and move it
The question was, is there work being done to manufacture something that's going to dissolve the plaque? Yes?
Yeah.
Yeah.
They have a little screen to catch that stuff. They come up with all the things.
Would be nice, but right this minute we don't have.
Like birds.
There's a question back there. Yes, ma'am.
What is your take on these advertisements for testing, like where you can get a whole your body tested with ultrasound, and you know what I'm talking about? Yeah, what is your take on that?
It's a good service. It's a superficial service, and if an abnormality is found, you're going to be told to follow up with your doctor. Many times it's a relatively cost-appropriate service where 3 or 4 scans may be much less cost-wise than individual ones. Sometimes those scans are read by people in other states. And so I think first it's a service, and it's a good service. It's a screening service. I think the most important thing is once that document is created, once the scan is done, that report, you and that report go to your doctor. So now you're going to have a discussion about what those results were. The discussion may be, this is too superficial, we need to get something else. The discussion may be, this is a major problem, I need to send you to someone. So I think 2 important parts. 1, it's a good service. 2, get the information and take it to your doc. Okay. Yes?
Both my parents have had bypass surgeries, so it concerns me. Can you have a blockage and walk around and not know that you have a blockage?
Yes. Yes, you can. Because it takes a certain percentage of blockage to start to obstruct blood flow. So when we do angiograms, in the heart, for example, we're looking for 70% blockages in most of the places. There's one particular place, the left main, that we're actually looking for a 50% blockage. So it's entirely possible to have 30, 40% blockages and completely asymptomatic, running 5 miles a day. Okay? Yes?
I had a stress test. I'm diabetic. I get clear. But my doctor told me that I have to have another one, another better stress test with the contrast. Do I have to have it?
Well, so the only thing that you've done so far is walk on the treadmill?
Yeah.
Okay, without anything else?
Yeah.
Okay.
No, what would you?
With the EKG leads on. The regular treadmill is a very good screening test. A lot of it has to do with whether or not your electrocardiogram is normal to begin with. A lot of it has to do with what your pre-test probability of having the blockage is. So if I take a diabetic, hypertensive person with high cholesterol, I'm just going to exaggerate now, who also smokes, doing a regular treadmill on that person may not give me the proper information because that person has a high pre-test probability of having the blockages already. So if your doctor is concerned about does he have the truth, that may be why he's going to suggest for you to have the nuclear study in addition. Okay? Okay, but yes. Go ahead.
Is there any difference in Lipitor and Crestor?
Okay, the question is there any difference in Lipitor or Crestor? Now, when I'm going to give one of those drugs, I'm going to give it for the plaque stabilization, and there's much more with Lipitor than there is Crestor. Crestor is, I'm going to put it in the category, I'm just going to put it lower than Lipitor. Yes?
The thing is that I talked to some patients that had heart attacks, and they told me that they had to have some kind of bypasses. And I said, well, where did they get it? They said they got it from my leg. I said, okay, fine, I understand it registered. But what happens to the things that were removed from the leg after they get circulation? They pull it out.
In his infinite wisdom, God made you very well. Okay? And you got spare parts. And so the veins from the leg can be used for conduits. Sometimes even the arteries from the arm. You have some spare parts. All right. Yes, ma'am. What about pravastatin? Right. Okay. So that's the first one that I mentioned. Pravastatin is one of the oldest ones, and it's one of the ones with the most data. So there is plaque stabilization data with pravastatin. So pravastatin, Lipitor, Zocor, that's simvastatin. Those three, the top. Crestor, close.
Doctor,
Yes.
I don't think I know if I'm right. There is a lab test to find out some inflammation in the arteries before they.
Is there a lab test to find out something about the arteries before they close?
Yeah, inflammation in the arteries. No. I was reading something about the blood test before to find out in the arteries if there is some inflammation around the plaque.
There's something called a SED rate. That's an inflammation marker, but it's a very, very nonspecific inflammation marker. Okay? So it can be elevated in entities that have nothing to do with blockages, as well as it can with blockages. So it doesn't help us discriminate. We've looked for a long time to see if anti-inflammatory medicines would help with blockages. There was even a little information to say that there might have been bacteria in the plaque. And so there was a little bit of work to look to see if our patients just needed to be on antibiotics. So many of these things that we look for and look at just don't pan out. Yes, ma'am.
I'm a little curious on what that man said over there about his arms and that blockage. So you didn't go any further than that. So it doesn't matter if the two blockages that he has.
It's
not going to harm him. I mean, I'm just.
It really, the truth is that it really depends on what's there from a Doppler standpoint, okay? Patients who, for example, diabetes and renal failure to the point of dialysis. Their arteries get very small and calcified to the point that we sometimes can't even feel the pulses, to the point that sometimes they even have ulcers on the fingertips. But those arteries become so small that we can't do anything about it. And so the issue then gets to be, is there anything in the larger arteries that we can do something about? Yes, ma'am.
If you had a blockage removed from your, it was the left ventricle, how likely is that you would get another blockage?
Okay, now the question was if you have a blockage removed.
Yes. They went in and unblocked it.
Okay, so let's say blockage opened.
Yes.
Okay, because unless we actually use a tool to actually take the plaque out, we don't remove it.
Oh.
Okay, we modify it, we open it. Okay, so the question, how about the question like this? If you have an artery opened, what's the likelihood of the blockage coming back? Okay, so now, very important. We treat the blockages. The risk factors we treat, but it doesn't go away. Okay? It doesn't go away. So there are patients who have blockages in their arteries in their heart. We open the blockages. Those blockages can come back, especially if the risk factors aren't treated. Bypasses. We were talking about bypasses just a moment ago. When the bypass is done, that vein looks perfect. Blockages develop in those perfect veins eventually. So bypasses, 20% of the bypasses close in the first year and 2% per year after that. So by 10 years out, half of all the bypasses are closed because of the same risk factors that put the blockage there in the first place. Okay, that's why it's so important to manage the risk factors, because the problem, the disease, doesn't go away. Yes, ma'am.
On the list of risk factors, in the second row, what is that increased plasma homocysteine?
Yeah, it's a blood test that we thought, and I just left it here out of completeness.
I thought that was
It's,
what he was asking about.
it could have been. It could have been. Once in a great while, we'll find someone that this homocysteine is their only risk factor, or we think it is. And fortunately, the thing that can lower the homocysteine is some of those same cholesterol-lowering drugs that we use to lower your cholesterol. So there's not something separate to take. It's rare also that we use this as a screening test. So you're not going to walk into your doctor's office and he's going to say, let's screen you with a plasma homocysteine. Okay. Yes?
The risk when you're placing this thing, you move the plaque. What's the risk that if the plaque, piece of plaque move and goes?
Well, this is the question is the risk of something happening to the plaque when we do something to the plaque. Okay, so heart-wise now, we've moved from just balloons. So the best thing that a cardiologist can do with a heart artery these days is put a stent in there. We started out with just balloons. We would crack the plaque. Sometimes it was a good crack. Sometimes it was a bad crack. And a bad crack tears the artery. The best thing about the stents is that it seals everything. So no uncovered cracks in the artery. Okay? Now, is it possible for anything in one of these arteries to break off when we put anything inside? That's true. That's a real risk. For the heart, if something breaks off, it's going to go right down into a very small artery, very, very small artery, and stay there. It's not going to come out of the heart to go to the brain. Can't do that. Okay? Now, these procedures that we're talking about, all of these procedures have risk. All of them do. So, if we were doing a heart catheterization, for example, there is a 1% risk of injuring the artery in the groin. Many of us now are using the artery in the wrist. Much less than 1% possibility of injuring that artery. Back to the heart catheterization, there's a 1 in 1,000 possibility of heart attack. There's a 1 in 1,000 possibility of stroke. And these numbers have stayed pretty much the same. When we're going to take pictures of the carotid arteries, no matter what we do, there's a 1% possibility of stroke when we do that. When we're opening arteries in the legs, the young lady, that 35-year-old lady that I did this morning, I used a device to cut the plaque out. So I actually used a device that I cut the plaque out and actually brought the plaque out of her body. But before I did that, I put a little net on the other side of the blockage. And when we brought the net out, there was stuff in it, which if I hadn't put the net there, that stuff would have gone down into her foot, the same foot that I'm trying to give more blood flow to. So all of our invasive procedures, so when we're going to put something in the body now, all of our invasive procedures have risks. There are things that we do to try to decrease or eliminate the risk. Okay? Yes?
Are there certain states that have a problem, you know, that they decide to resort to a different kind of stent because of the company?
Well, we have gone through major changes in what stents are made from, how we put the designs in them, what they're coated with, a coating with a drug, without a drug, the composition of the stent, initially stainless steel, now made of something called cobalt and chromium, lots of different things. And the reason for that is improvement in the designs, okay? And so hopefully what we're doing is not just making something else to buy, but we're making something better. And we're still at it.
So you're improving on what you already have?
Absolutely. And here, Valley Baptist, once something clearly is better, we get it. Yes, ma'am.
In your carotid arteries, what percentage of blockage would you have to have in there before they would attempt to clean them up?
Okay. 2 categories: symptomatic category, asymptomatic category. Most of the patients with blockages in the carotids are asymptomatic, which means no stroke, no TIAs. No little strokes where all the neurological deficit returns. So in that group, very clearly, we're looking for 80% blockages. Okay? In that group of asymptomatic patients, we're looking for 80% blockages in those arteries going to the brain. The group that's having symptoms, so there are little particles breaking off, going to the brain, little strokes, TIAs, 50% blockage if that's the culprit. So the difference in those 2 numbers has to do with whether or not the patient is symptomatic or not. Okay. Yes, ma'am.
What are the symptoms like you have blockage in your legs besides the thinking? Because sometimes when we ignore those, the pain will get, but it starts getting worse. So what are the symptoms when you know that it doesn't come with swelling or pain?
Okay, I think the question is symptoms that are due to blockages in the legs when they're getting worse?
Yes.
Okay.
Because sometimes, you know, I mean, you just mentioned when you were doing it at the beginning that you get that feeling of being tired, of, you know, that your feet hurt. But do they get swollen? Do they,
Okay.
What's
Now, generally swelling, the legs swelling, usually that's not because of an artery blockage until we're pretty much at the end, that tissue is dying and fluid is in the tissue. many times the swelling is vein. If you look at the back of your hand, those things that you can see, those are veins, okay? And there are big veins throughout the body that can also have problems. When I'm talking about blockages, I'm talking about arteries. So if you feel a pulse, that's an artery. So the swelling in the legs usually is not the arteries. It could be the veins, it could be medicines that you're taking. Today in my office, there was actually a man whose leg was swelling. And in that particular instance, we found a particular vein in his leg responsible for the swelling. And I actually used radio frequency waves to close that vein. Now, all my other comments tonight have been about opening something, right? Okay. There are very few instances when I actually want to close something. So the swelling issue, there are multiple reasons for swelling, and those all have to be looked at. The cramping at night, in bed at night, that's not artery. That part's not artery. The artery symptoms are more related to physical activity when you're using the muscles. So when the muscles aren't getting enough blood, they hurt. If you're lying in bed and having cramping, muscles aren't working very much, that's not an artery thing.
Is
Okay?
that lack of exercise? Is that what you're saying?
The cramping or the, which
You're
one?
saying the cramping that you say
At
not
night?
enough muscle activity?
No. What I'm saying is that the symptoms related to decreased artery flow are because the muscles aren't getting enough blood flow when you're working them, when you're actually working them. And therefore, when you stop working them, as in stopping walking, sitting down, the discomfort goes away. Yes, ma'am.
Surgery 3 years ago.
So bypass surgery 3 years ago.
So you're saying already some of that they could be closing?
It's entirely possible. If I put a catheter in to you today and I found one of those veins blocked, I would not be surprised. Now, hopefully, all of them will stay open for 10 plus years, but statistically, I wouldn't be surprised to find one closed. And you may or may not even know about it.
Well, I didn't know I had heart disease. I
Mhm.
just went and they gave me that chemically.
Mhm.
I had to have surgery that night in the morning.
Good. Yes, ma'am.
I wrote it down because I always forget.
Okay.
Is it possible that a person that has stabilized plaque with meds eventually beat the use of the meds, or do you recommend meds long-term after their initial blockage?
Okay. So now, you have a blockage, and the deal is to try to prevent you from developing any more. So now, let's just say person comes into the emergency room having a heart attack. I take him to the cath lab, open the blockage, the heart attack's done. They're going to go out of the hospital on, I'm going to say, a minimum of 5 new medicines. Let's just say they weren't taking any when they came in. Okay? So, they came in having a heart attack. I open the artery, I put a stent in. So, they're going to go home on about 5 medicines. 5 medicines that have been proven to give us a certain outcome. So, in that patient, aspirin is going to be there for the rest of their lives. Doesn't matter what else, aspirin for the rest of their lives.
81 milligrams?
Well, we may start out with 325, but we'll certainly go down to 81. Aspirin is one of those things that was safe. 81 is a lot safer than 325 from the gastric bleeding standpoint. Okay, so aspirin, yes. That person is going to take a cholesterol-lowering drug for the rest of their lives, regardless of what their cholesterol is. Okay? Now, I put a stent in. There's a medicine called Plavix, and there are others. In the beginning, we thought, once on Plavix, Plavix for the rest of your life. We thought that, and we did that early days. And that's not the truth now. We know that the benefit of Plavix for the heart stops at about a year. And the risk of Plavix, which is a little risk of bleeding, that continues after a year. So after a year, the risk is a little bit higher than the benefit. So Plavix for a year, then the Plavix comes away.
And then you don't do it. Aspirin,
Aspirin has been there for all along, and it's going to stay all along. Okay?
the 81 after the Plavix.
Correct. But you were taking the Plavix and the aspirin. It's just the Plavix goes away after a year. Okay? Now, there are two other medicines. One is in a category called a beta blocker, like Lopressor or metoprolol. Lopressor, metoprolol. And there are others. Atenolol. Those are beta blockers. If a person has a heart attack and takes a beta blocker afterwards, their risk of having another heart attack is lower. If you don't take the beta blocker, your risk of heart attack is higher. So basically, patients who've had heart attacks now should be on a beta blocker for the rest of their lives. Okay? There's another category of drug called an ACE inhibitor, like lisinopril and ramipril and monopril and all those pril drugs. Many of those pril drugs have also been proven to decrease the chance of having another heart attack. So some of these medicines that have this reproducible benefit after a heart attack, the patient is just going to be on them for the rest of their lives. Now, I use the heart as an example. In the legs, if I open an artery in the leg, like this lady this morning, she's going to be on an aspirin. She's going to be on a cholesterol drug. She's going to be on Plavix. I'm going to try to get her to a year. There's one study that says 3 years. We try to get to 1. Those other two categories, the beta blocker and the ACE inhibitors, aren't as important for that person that I open the arteries in the leg as the one in the heart. So what we try to do is to match your treatment and what we know about the prevention of these with some of these drugs with where the blockage is. It would be very nice if a blockage is a blockage is a blockage, and it doesn't matter where it is, we do the same thing. It just hasn't panned out that way. And the duration of the Plavix hasn't panned out that way. Answer, long answer? Did I answer or? Okay, all right. Okay.
We have time for one more question.
Okay.
Aspirin morning and evening, or just?
Aspirin should really be once a day. The platelet, what we're trying to do here with the aspirin is to have this little tiny blood cell called a platelet not stick together. Aspirin once a day is fine.
It doesn't matter which time of the day?
It doesn't matter which time of the day.
Ladies and
Okay.
gentlemen, Dr. Farley Neasman.
All right. Thanks very much.